Ruff, and I have the honor of being the AOA faculty counselor, and to welcome you to the annual AOA Spring Lecture, which is part of a day of celebrations, including our luncheon, and tonight we have our banquet and ceremony. And so right now I'm honored to introduce Dr. Peter Pronovost as our speaker for the annual AOA Spring Lecture, speaking on healing in the hospital to healthy at home, a new narrative for value. Dr. Pronovost is a world-renowned patient safety champion, a critical care physician, and a prolific researcher, publishing over 800 peer-review publications, and a global thought leader, really shaping U.S. and global health policy. And his scientific work, which leverages checklists to reduce catheter-related bloodstream infections, has literally saved thousands of lives and earned him well-deserved recognition, including a coveted MacArthur Foundation Genius Grant and being named one of the 100 most influential people in the world by Time Magazine. And we're very fortunate to have Dr. Pronovost here at the School of Medicine, where he's a clinical professor of anesthesiology and critical care medicine, as well as at UH, where he is the Chief Clinical Transformation Officer for the system. So welcome, Dr. Pronovost. Thank you for being here.
Thank you for having me. So first, can I see a show of hands of the AOA inductees? Awesome. Congratulations to you. Well deserved. It's an important role. Some context for the presentation we'll be having. The kind of work that we're going to be talking about is what I call, or many call, implementation science. And it varies from traditional biomedical research, in that traditional biomedical research generally tests, is Coke better than Pepsi? In other words, it's this understanding biology, I'm comparing things. What this work does, it's much more like an engineer. It starts at an end game of I want to achieve some outcome, and then packages a multifaceted and often multi-level, meaning board, management, team, clinician, interventions to achieve that goal. So it's a very different type of mindset. It's a kind of research that's just burgeoning in some health systems. We're trying to kickstart it at CASE and within UH. But as you hear this, keep that kind of context in mind, because it's a different type of research. Okay, context. As you will now all be graduating, you have learned that medicine performs marvels every day. You have an amazing capacity to heal hearts, to cure cancers, and to mend minds. Yet medicine today still has preventable harm as the third leading cause of death in America. And if we add failure to control blood pressure, or failure to treat COPD, or failure to treat diabetes, or misdiagnosis, because none of those are counted in that third leading cause of death, preventable harm is by far the leading cause of death in America. And it doesn't need to wait for a cure. The cure is in the delivery system. We just have to do delivery science to apply it. And medicine today squanders a third of every dollar we spend on therapies that don't get patients well. Collectively, that's a mind-numbing $1.2 trillion. Locally, it's $10,000 per household in America. That's more than the median net worth of the people who live around this neighborhood. And if you look at every payer of health care, the federal government, state government, local municipalities, employers, and us as consumers of health care, our health expenses are going up more than our revenues. And you don't need to be a math major to know that equation doesn't work for too long. And the states that have expanded coverage, and I believe deeply that a country as rich as ours ought to give insurance, they did it, but they did it at the expense of every other social good. So look at Massachusetts' budget. Healthcare expansion, STEM budget cut by 20%. Preschool budget, 20%. Elder care, 20%. Parks and recreation, 20% down. And so us not getting this right is truly the future of the American dream, because it's at the expense of every other social goods. So what's going on nationally to address this? Well, CMS primarily, but private insurers are creating a whole lot of mechanisms to drive us to being paid for value rather than for volume. And you may have heard that tune. And the amount of money at risk is going up almost weekly. The amount of patients at risk is going weekly. But let me share with you a story of Helen to put this into context. We were just reviewing our UH's budget, and our hospital discharges are up. We're meeting our projected budget revenue, and we look at that as if it's a good thing. But within those numbers, 30% of all of our admissions had been readmitted within 90 days, 30%. And when you unpack that, we come across Helen. Helen is a 62-year-old African-American woman who has heart failure and was admitted 35 times this last year and had about 13 emergency department visits. And every one of those discharges under paid for value is counted in the good column, right? Filling our discharges, hospitals filled. But from our perspective, from society's perspective, they're all defects, right? They shouldn't be good. And so now we have to say, well, how do we think about changing that narrative so success isn't having Helen heal in hospital, success is having Helen be healthy at home. And when we unpacked why Helen was admitted so much, she, on one hand, wasn't really trained in self-management because they had a whole lot of people caring for her, but no one really owned that piece. And something as simple as she couldn't get away to come to the doctor because her daughter died in childbirth, and as you know, the inequities in maternal mortality are enormous. And that her granddaughter was a NICU baby who has a lot of disabilities, so she's the primary caregiver of that baby. So Helen gets readmitted all the time because the only time she goes to get care is when it's an emergency and she's in crisis and she calls. But the system is letting her down and could do better. So these federal incentives to start paying us for that are needed, and we need to do it, but they won't solve the problem. They don't deliver care. They don't coordinate care. You coordinate care, and what we're here to talk about is what's keeping us from doing that. And it isn't something that's esoteric. It is the stories that we tell, the stories you tell. Now, before we get into that, especially for our AOA students, I want you to think of the words, I will. Because though I'm honored to come and do this lecture here today, the point isn't just to come and give you a lecture. The point is that you go do something because you are the future leaders of American medicine, and our patients are counting on you to start to change some of this system. And so at the end of this, we'll ask you for what your I will statement. Now, I mentioned what is going to lead to the change, and it's the stories that you tell yourself. You see, stories are the most potent force for change in the world. The stories of democracy and free markets have lifted more people out of poverty. Sure, they have their shortcomings, but that fundamental story was transformative. Stories of whether you see your colleagues in nursing or in other disciplines as competitors or collaborators. Stories whether you see yourself as powerful or powerless. You change the story and you change everything. Probably the greatest example of that is JFK's story of I Want a Man on the Moon and all that led to. Well, there's 3 dysfunctional stories that I'd like to share with you that we might explore how we could have new narratives. The first dysfunctional story is that we still accept harm as inevitable rather than preventable. We say the words harm is preventable, but the reality is we don't believe it, because if we did believe it, having preventable harm as the #1 cause of death, having stories like Helen every day in our health system would cause moral outrage and a heck of a lot more action than we happen to see right now. We get it. I still don't tell that story. My own personal journey to reframe that story began quite humbly and tragically in 2001 on a snowy night in February in a dark corner of the pediatric ICU when this little girl, Josie King, who looked hauntingly like my daughter and was born just days apart, was taken off of life support and died in her mother's arms. She had been burned, but a catheter infection sacrificed her. Now, at the time, these catheter infections, one small piece of care that you probably never even had a lecture on killed more people than breast or prostate cancer. Think about that. More people than breast or prostate cancer. And we just accepted it as the cost of doing business. We thought when you care for sick people or old or young people, or you do big operations, sometimes little girls like Josie are going to die. And she did. Her mother, an amazing woman, came to challenge me and said, could you tell me that this won't happen to my other daughters? And I looked at it and started telling her what we're doing, and I paused and said, I can't. We don't have a science-based program. Our rates are sky high. We don't have good teamwork. I'm sorry, but I wish I could. I can't. But then she asked me something that changed my life. She said, Peter, what are you going to do about it? And in that moment, I knew we had to change the narrative from accepting these as inevitable to doing something about it. So we did something that my colleagues thought I was off my rocker. We declared a goal of 0 infections. Everybody pushed back and said, but we're at the CDC average. I said, yeah, the CDC average is half the people in the country not doing what they're supposed to. It's stalling progress, not helping us. We will be 0. We made a checklist of best practices. We encouraged doctors and nurses to work together and empowered nurses to say, if the doctors don't use this checklist, you could stop takeoff. No questions asked. We investigated every infection as a defect. We fed data back into the system, and we created a management and accountability system. And these infections that used to kill more people than breast or prostate cancer are now down 90% across the whole country, 90% in about 15 other countries. So we got curious and said, what happened here? Because if we could understand this as a learning exercise, we have a really potent tool for change. So we partnered with some of my anthropology colleagues and medical sociologists and interviewed clinicians. And when we spoke with them, you could immediately see in their eyes what they believed in their heart. What they said was different was they told a new story. You see, they all started saying, oh, these things happen, and I'm just a fill in the blank. I'm just a resident. I'm just a nurse. I'm just a medical student. I'm just an attending. Nothing I could do about it. And what got to 0 was they changed that narrative to say, no, these are preventable, and I am capable of doing something about it. So we got curious and said, well, what leads to that new narrative? And it turns out there's a pretty robust social science literature on this, some of it from education, and we validated it. It was 2 simple things: believing and belonging. Leaders believed they can get to 0 and infected that belief in others. If you want a powerful example of that belief system, take the example of Roger Bannister, who, as a medical student in Oxford, go Tribe, in 1954 broke the 4-minute mile. I'm a runner, so I happen to like this story. But prior to him breaking that, for 2,000 years, leading scientists said, it is physiologically impossible to do this. You will die trying. Well, Bannister didn't die. You may know that. But what's often not known is next year, 2,000-year-old record, 12 people broke it. The year after that, 156 people broke it. And the last New York Marathon, you may have seen, the guy ran the whole marathon at a 4-minute mile pace. So what changed in 1954? Wasn't doping, wasn't steroids, wasn't evolution. It was their belief. Bannister freed up all of them to break that 4-minute impossibility. And my friends, that's what healthcare needs you to do for your challenge. The second thing that leads to new narratives isn't economic intensive or what's called extrinsic motivation. I'm going to give you a nickel or take a nickel away from you. It was belonging to a peer learning community. They're the most powerful tools for learning and collaboration. Example of that comes from Mary Poppins. How many of you have seen Mary Poppins? Right, so you probably know or recognize a very prominent feature in the background are these birds chirping when she's skipping through the park, when she's flying down with her umbrella, when she's playing with the children. And that's because London was full of 2 types of melodious songbirds in the late 1950s, the red robins and the blue tits. And they thrived in downtown London because they used to peck through the top of the milk containers that were left on people's stoops. They sucked the fat out, and they were really chubby, really plump, really happy birds who were singing their songs out. And that's what London was like. But then, in the late 1949, the milk companies changed the containers from being cardboard and steepled to aluminum and flat. And it required that both birds learn a new technique. They had to peck differently. And both birds are equally smart. But the red robins are extinct now in London, and the blue tits thrive. And the only difference is the red robins were solitary birds. They had their stoop or their corner. We call it our specialty or our department or our hospital, and that wisdom never disseminated. The blue tits are flocking birds. They fly strong and proud together, so they had a structure to allow for that wisdom and information to flow through. And if I think about literally every problem we're facing in healthcare on this third leading cause of death, even just within the UHK system, somebody knows how to solve this problem. We just don't have the culture or the structure to connect those ideas and get it into the common pool of meaning. And that's the kind of structures and cultures that we're going to need. Second narrative is we say healthcare is a system. We even call ourselves a healthcare system. And we are the furthest thing from a system. You see, a system, and I'm not an engineer, but this is well defined by engineers, is a set of parts interacting to achieve a goal. We've bought or built the parts. We haven't agreed upon the goals. We now finally are agreeing on the goal is driving up value, but we haven't hardwired the connection between the parts. So in Helen's case, at every step of those 35 admissions, she got great care. When she showed up in the ED, they turned her up. When she was admitted to the hospital, they tuned her up. But that's not good enough. We have to hardwire the parts to begin to think about this as a more disciplined system. I learned about this idea of working as a system when I visited an aircraft carrier. Aircraft carriers are the prototype or what are called a high reliability organization, or they apply these principles of high reliability organizing. Those of you who've studied safety, and hopefully our med students got exposed to it, these are industries that work in really hazardous and dynamic conditions, but perform almost flawlessly. Aircraft carriers, inland firefighters, nuclear power plants are example of that. And I went to visit the Admiral to understand what they do. And truth be told, I was probably a little whining to say how hard it is in healthcare where you have residents and med students and nursing students all rotating. And the Admiral quickly cut me off and said, "Let me explain to you my world. I am out in the middle of the ocean in 60-foot waves. We are pitching at 30-degree angles continuously and at random intervals, and we land a plane with enough bombs every 3 seconds flawlessly. And each of those planes, if it didn't go right, would blow the ship up. And your residents and turning over, get over it. We change our entire crew every 6 months. Our average age is 18, and they have a high school degree. Stop whining and start leading." Whoa. And standing next to that guy was a gentleman sweeping the deck. Now, that gentleman on the power hierarchy is way below the Admiral, right? The difference in stature, in education, in pay. But on the safety hierarchy, they're exactly equal. Exactly equal. Because if there's a hammer or debris on that flight deck, it comes down, they hit it, they all blow up. I asked that gentleman what job he did, and I was blown away. He stood up tall and proud, looked me in the eye, and said, "Sir, I help planes take off and land safely to serve the mission of the United States." I said, "Whoa, that is a worker connected to purpose." To purpose. I left there and walked into many of our hospitals and asked our EVS workers, "What job do you do?" Same power dynamics, way below the CEO of a hospital or a system, but safety exactly the same, because if they don't clean for MRSA or C. diff, patients die. And what do you think her response was when I asked a woman what job she did? She didn't stand up tall and proud. She looked away, almost shameful, and said, "I clean the rooms." I said, "No, you prevent infections. We need you to prevent infections." I walked into a call center and said, "What job do you do?" I said, "I answer the phones." I said, "Oh, you heal people, you comfort people. When people are calling to access care, they're scared, they're frustrated, they've likely waited on the phone call. You are a healer." But we in healthcare hasn't taken this mantra that our job is to make sure every employee is connected to the purpose. And you graduates will have that ability to go do that, something as simple as thanking the people who clean the rooms for preventing infections. What would it look like if we were a system? Well, care would be organized around patients' needs. I was just diving into our breast cancer care. It's one of any examples where we have brilliant med-onc, surg-onc, rad-onc, but it's all organized around them. And we did a patient journey flow map of what's it like to be a breast cancer patient here, from when I find a mass or have a mammogram to getting a biopsy to starting chemo. And what we found is it really hadn't been mapped because it wasn't in anybody's bucket, but the time to treat, when we put just a simple measure of how long it takes to go through each of those cycles, because when you're worried about cancer, time is suffering, right? That 2-week waiting to get a path report back is you don't sleep. Your family doesn't sleep. You're worried. We had ridiculously long wait times on average because nobody managed it, because it wasn't organized around patients' needs. It was organized around, once you got plugged in to come to the radonc, you got brilliant care or surgical care. But getting there, you're lucky if you found your way, because we haven't organized around patient care. If we were a system, we would anchor care in primary care. Any example nationally, what % of people are discharged from the hospital or the emergency department and have a primary care follow-up schedule when they leave? So figure if you're sick enough to be in the hospital, you probably need to get connected to care. Any guesses? 2%. We were at 2%. We're now at about 50% or 52% just in a few short months of pushing hard on this. But that's ridiculous. Why? Because the people saw through their narrow lens of, I did my job of getting you out of the hospital, and they did it well, but their narrative wasn't that I needed to think as a system. We need to change that. If we were a system, we would, what I call, reduce mindless variation and augment mindful variation. And this is perhaps one of your greatest challenges that will be. You see, when you look around healthcare, it is full of mindless variation. Mindless variation, in my definition, and you could criticize me for it, is variation either because we didn't take the time to make a pathway or standardize things, or much more often because of my power or stature. I want to do it my way because I'm the attending, because I'm the department chair, because this is the way I want to do it. Not because it's evidence-based, not because it's science-based, simply because. And there's no room for that kind of ego in medicine. At the same time, we need to augment mindful variation. That is variation because of your experience that you say, this patient's different. I need to deviate from that. Or because of this genetic thing. But it's variation based on a hunch or a hypothesis. And mindful variation imparts an obligation that you learn if that hunch is right. And we almost never learn. We do the variation, but the wisdom or the potential wisdom is lost. And we have to dampen down that. And finally, if we were a system, we would hardwire the connections at every handoff in the journey. We would intentionally think, wherever you're going next, I'm not leaving a chance. We're going to schedule or plug you in to that part of the journey so that we make sure we truly perform as a system for our patients. The third narrative that I'll share you with is value is not my responsibility. And I would posit that it has to be all of our responsibilities. All of our responsibilities. And by value, we define it, or different definitions, we're defining it here at UH as the quality of care plus patient's experience over the annual total cost of care. And annual total cost of care forces us to think differently. Why annual total cost of care? Because that is what every payer looks at when they're trying to decide where patients are going to go. It's what we as people pay out of our pocket, out of our annual budgets, and it forces us to think differently. You see, if we did, we wouldn't be counting all those admissions that Helen had as in the good box because they're filling our discharge and we're getting revenue. They would be seen as defects, and that $1.2 million spent she had and her granddaughter's $800,000 NICU stay because she didn't get prenatal care would be viewed as defects, not something that's filling our volume. But we haven't thought that way. And we need to give you another example of the same mindset. We had an awful lot of readmissions to our emergency department that were sickle cell patients. And our sickle cell population is big, but it's not that big. I said, why the heck do we have so many of these sickle cell patients come into our ED? And so I looked and saw their care plans literally said, go to the ED if you have pain. Now, you're graduates, but you probably know I couldn't think of a worse place to manage pain than going to be in the ED and waiting for 4 hours. So we dug into it, and what did we found? Well, we have a sickle cell clinic that it's under really high pressure for RVUs to churn patients. Pain is part of the disease, but people on narcotics take longer time to care for us. You know, they're more complex. And we made a plan that we were going to kick people who are on narcotics out of the sickle cell clinic because they took too long so I can churn the RVUs. Right? If I'm optimizing the part, that makes perfect sense for optimizing the part. But we have optimized the parts too long and it sacrifices value. We have to say whatever resources you need, whether it's behavioral health or social work, we need to put it in there because having these repeat visits to the emergency department as the place to go for pain management are defects. Now, not that I have a checklist fetish, but okay, I admit I do have a checklist fetish, so accept that. When we think about how we might gauge eliminating these defects in value, and truly all defects in value, I put them into 3 categories, and it's all of our jobs to do this. The first is defects in helping people stay well, and my friend, that includes ourselves. Any guess amongst the UH employees, what % of our patients do an annual wellness exam? And you probably know the literature, except maybe if you're a millennial, but you're middle-aged and beyond, great data, you have an annual wellness exam, your health is better. Any guess of how often we do it? 13% of the time. How about employees who get a mammogram? 20% of the time. How about colonoscopy? Maybe I think it's like 25 or 30% of the time. But what this means when you think in terms of defects or end game, that means amongst our employees or their beneficiaries, we insure about 42,000 people now. We have people with needless breast cancers. We have people with cervical cancers because our cervical cancer screen is in the mid-30s and our immunization rates for that is equally abysmal. We have people with colon cancers that could be prevented, but we didn't eliminate these defects. Second domain is how well do we help people get well? What do we mean by that? Well, you could take any chronic disease, whether it's diabetes, heart failure, COPD, depression, anxiety, and there's defects in this pathway. Let's take diabetes, for example. How often are people accurately diagnosed? Any guess nationally what % of diabetics have the disease or have a high sugar or A1C in their EMR somewhere but aren't diagnosed with diabetes? 40%. Hypertension, it's about the same number. What % of diabetics are on guideline recommended therapy? 50%. That mindless variation that exists because if you look at how many of them have their physiologically controlled, meaning their A1C is controlled, their lipids, and their blood pressure, all that leads to stroke, and 13% of diabetics have those things controlled. And how many of them have avoidable ED and hospital utilization? 90%. Not surprisingly, because that last defect is the upstream product. And who owns all of those? Right now, none of these defects are visible in the EMR. We are aggressively working with our IT folks to make this dashboard visible for a variety of diseases, and it will be in the next couple of weeks. We're prototyping it. But who owns this? Because we see this every day in practice. The question is, what are we doing about it? And the last domain is how well are we managing an acute condition? And the defects there, and you can make your own defects, this is just my brainstorming, is care coordinated with primary care? Second domain is what we're recommending appropriate? You've heard about these centers of excellence that we have or that are around the country in in joints, in bariatric surgery, in spine surgery. Any guess the one thing that employers contract with health systems for centers of excellence for? One thing that they do. They don't operate on 30% of the people. Because literally every procedure that's been looked at, 30% of them, if you have an expert consultation, aren't needed. For spine surgery, it's a whopping 44%. It's because it's quite subjective of who needs it. 40% of the time, you go to a center of excellence, they'll say, no, you don't need surgery. Joints, it's about 30%, and cardiac interventions, it's around 24%. Is the site of service optimal? 40% of the care that we give is in a higher cost setting that could be given in an equal or higher quality, lower cost setting that we don't do it. Estimates are 40 to 70% of patients who show up in the ED could be cared for elsewhere. Many of the surgeries you do in an expensive place like CMC could be done in an ambulatory surgery center. About a third or 40% of the people who go to SNF, no reason to be there. They'd much higher quality being at home, but for a variety of reasons, some of it which, because some of the physicians have medical directorships at the SNFs, they send people there rather than being at home, and all that waste is costing the public. So we need to start to change it. So what's UH doing about that? And we're aggressively working on this. Well, our ACO is lazily focusing on ensuring our people, our employees are as healthy as they could be so that they could live life to the fullest. And our ACO patients receive the highest value care, and those who ultimately pay for care are getting the highest value care. To put this into context, UH is now the ninth largest ACO in the country. We have just under 600,000 people in some kind of ACO arrangement. That means we get some benefit or risk in that annual total cost of care, and this numbers are growing exponentially. Just 2 years ago, it was maybe about 300,000 or 250. UH cares for 1.2 million people, so roughly half our patients are in some kind of these risk arrangements. And we're aggressively working to drive up value. I'll share one really innovative idea that we are finalizing a grant with CMS to be a national model. If you look at what keeps people healthy at home, there's what we call, we've been calling this web of well-being. And that is there's 4 domains of interventions that there's quite good evidence to keep people healthy at home, but we've never integrated. The first is, are people skilled in self-management? It's the same thing in pediatrics for asthma, for COPD. The estimates are it's probably fewer than 20% of people are skilled in self-management. Our School of Nursing has a brilliant center, one of the national leaders on self-management. We don't really have great content in the delivery system yet. We don't have an assigned an owner who owns that, but we are and are committed to say 100% of our patients with heart failure and COPD will get cared in self-management. Second domain is connecting their families or community health workers or community resources to support people, to further reinforce that self-management, but also to provide the transportation and the services they need. The next ring, and this is really innovative, I hope some of you take it on, is thinking about what's the dose of ambulatory care. So let's take a step back. We titrate drugs, so say a beta blocker, to achieve an endpoint, a heart rate, or insulin to achieve a glucose. I asked our primary care and specialty doctors, what do you titrate your dose of ambulatory care? Because when we have a 43% readmission at 90 days for heart failure, it seems like the dose is too low. And the question there was an aha went off. They're like, never thought of it before. I guess I don't really titrate it to anything. I probably titrate it to when my clinic's available. And I said, okay, not good enough. What if we titrate it to prevent avoidable ED and hospitalizations? What would that look like? And by ambulatory care, I don't just mean the physician side. I mean home health care. I mean chatbot. I mean a call from a nurse at the ACO. I mean telemedicine visits. I mean a PCP visit and a specialty visit. So to give an example, Helen now, if she gets discharged, will have home health visit at day 1, who makes sure that they're skilled in self-management, a call from a navigator day 2, another call day 3, a cardiology visit day 4, a cardiology visit every 2 weeks. And is every 2 weeks the right dose? Who the heck knows? I just know seeing them randomly isn't enough dose, so we're titrating it up and we'll figure it out over time. Intermittently, they get a call to follow up with them every other week. And we're documenting compliance with self-management with a chatbot called Conversa that just would kind of reiterate with them if they don't do it. And then finally, the acute care network, where we now have plans or programs that if you show up with heart failure in the ED, you will be discharged to home with a home health nurse there in 2 hours who stays for 5-day intensive care to make sure that you're getting the care you need. Right? All this creating this web of well-being. So I'll close with a challenge to say, you as you go out into your practice, the question is, what narratives are you going to tell? Are you going to say defects are inevitable, healthcare really isn't a system, and value's not my responsibility? Or will you take this up and to say, no, we will commit to eliminate these defects in value and make healthcare work as a system? Because you're the ones who are going to have to take on that challenge. Now, this might sound like a daunting task, and trust me, it is. It's really frightening because we're inventing it. This is a complex problem. There's no right answers to complex problems. You have to iterate and experience, and we'll get it wrong, and we'll try to learn fast. But I would encourage you to take comfort that though this seems like it's a huge transformation, it's based on something very simple and something very human and something that's grounded in medicine, and that is love. And by love, I don't mean a 50-year marriage. By love, I mean what the psychologist Barbara Friedrichsen describes in her book, Love 2.0. It's an amazing book if you're interested in this. She studies the biology of love, literally what makes oxytocin spike. As you all know, oxytocin, the cuddle hormone, and find oxytocin spikes from micro moments of positive connection. Micro moments. The idea is I feel warm towards you, you feel warm towards me, and we create energy. And I ask the students, if you think about your most memorable experience in medical school, I guarantee you it's a micro moment. It's some moment of love, of connection with the patient. It's not some great diagnosis. It's not some great surgical that you did or participated in. It's something very human. Love is that hand on a worried patient. Love is listening to colleagues who just made a mistake. Love is that respectful smile for a homeless person. You see, this big change in healthcare, and it's scary, is the sum of thousands of small ones, and every one is facilitated by these micro moments. Because change progresses at the speed of trust, and trust grows through these relationships, through having these micro moments of connections. And the beautiful thing about these micro moments is they're contagious. I don't know if any of you read the literature of the work of the physician sociologist Nick Christakis in a book called Connected. He published it in the New England Journal of Medicine, which he showed if we infect the behaviors and feelings to our teams, that if you put a fit person in a circle of friends, every one of those friends are more likely to be fit. And the treatment effect goes out 2 networks deep. So their friends, even though they never met that person, are more likely to be fit. And their friends, the treatment effect goes down, but it still exists 3 networks deep. You put a jerk, same thing on a team, and everyone's more likely to be grumpy and jerky. We've all experienced same thing. But you put someone who creates micro moments, and that cascades. I learned about this in a surprising and perhaps unusual way in Dunkin' Donuts. I'm an intensive care physician, and tradition is on Sunday mornings we would stop and buy bagels or donuts for the staff who work in the ICU overnight. And this was when I was in Baltimore. And the Dunkin' Donuts I stopped at was near a homeless shelter and around the corner from a bail bonds. And so in Sunday morning, Dunkin' Donuts was half homeless people, half people going about their work, doctors, nurses, firefighters, police, Sunday school teachers. And I'm in line on a cold morning just before Valentine's Day, and there was a homeless couple in front of me. They never really saw a homeless couple, and they were dirty, yet deeply in love. And they were reaching in their pocket to see if they had enough change to buy the heart-shaped donut with pink frosting that Dunkin' Donuts releases at the holidays. You may have eaten or had it. And they were a nickel short. And the woman kind of sheepishly turns around and says, "Hey, could you give us a nickel?" And I was feeling rather guilty because I'm buying bagels and donuts for most of the people who don't need them. And this was probably going to be their only meal that they had that day. So I said, I'm getting a big order. Just go ahead and order breakfast and tell them to put it on my tab. So they went up there, and the cashier must have had implicit bias because the cashier instantly said, "You can't order all that food. You don't have any money." And the guy made a scene of it and said, no, the person behind me said he'd buy me the food. He'd buy me breakfast. And I said, "Yes, I'm buying a breakfast. They can get whatever they want." Well, there was a nurse standing next to me who turned to the homeless person next to her and said, "Hey, can I buy you breakfast?" There was a cop on the other side of me who said, "Hey, could I buy you breakfast?" There was a Sunday school teacher behind him who brought him breakfast. And this love cascade literally went 7 people deep in 30 seconds. It was the most amazing thing I've ever experienced in my life. I was quite moved by it. And I was walking out, and the couple said, "Would you mind speaking with us for a minute?" And I said, sure. And he said, we're not nobodies. We made some bad decisions in our life. And I said, yeah, you and all of us. But we're going to get our act together. And I said, I believe so much you're going to get act together. Do me a favor. When you do, buy somebody breakfast. So fast forward to June, Sunday morning, I'm schlepping in there, half asleep, to Dunkin' Donuts. I walk up to get the order, and the cashier said, hey, Doc, some guy left this note for you. And written in a little crinkled piece of paper was a note that said, I bought somebody breakfast. Really quite moving. And I was touched by that. I went back on rounds, and this may not be true in CASE or UH, but love isn't the most common talk of rounds in the surgical ICU. I know you find that hard to believe. And I was sharing the story about this, and I was quite moved. And our rounds are quite interdisciplinary, meaning the families are invited, all the staff are invited, and EVS is part of the rounds. And one of our EVS workers on rounds, Devon Johnson, spoke up and said, Peter, I used to be one of those homeless people in that, our own employee who had some tough times, and what I would have given for someone to believe in me. So my friends and graduates, I hope you take on the challenge to go create micro moments, and I'd love to hear your I will statements. Because if we are going to create the kind of health system that we all desire, that our patients deserve, and the public demands, it's going to be you who creates it. So thank you, and I think we have time for questions. Or your I will statements, sure.
I think you're equating love with empathy. Is that what you mean?
You tell me, what does that mean? How do you define empathy?
Empathy is having a caring attitude towards a fellow human being. Okay? Empathy in many cases may be either inborn or it can be taught.
Correct.
And I think when we use the word love, many people may not understand what we are teaching, what we mean. I think we want to teach empathy to our medical students, to be very caring physicians. That is
Yeah, you're absolutely great point. I was literally using that kind of scientific definition from that Barbara Friedrichsen, who saw it's a she literally studies what makes oxytocin spike. But you're absolutely right. It's encompassed with love. I'll share with you your point about this. I submitted a paper to JAMA with the title called From Shame to Guilt to Love, How We Respond to Medical Errors. And when I submitted it, the JAMA editor literally sent it immediately back and said, I think you have the wrong journal. You have the word love in it. And I said, no, Howard, thanks. It actually is the right journal. Could you please read it? And it was published, and it got like many of the medical educators used it. And it was this point about how do we react to errors. We often shame people. You'll never be a good doctor. It's what I grew up with. Hopefully we're not that bad yet, but we're still, to making you feel guilty, which narrows your view to, in my view, love, where you can be both empathic and yet accountable, right? I could recognize that there was a mistake, and I could understand the system, but I could also then be responsible to fix it. So if my sense is a lot of these feelings are these words are overlapping. The point, though, that one of the points you're making is when I think about the kind of culture that makes care safe, and the culture that makes patient experience great, the work that Joan leads, and the kind of culture that makes work joyful, we use different words, but fundamentally it is the exact same culture, right? It's this culture of mutual connection. It's of these micro moments we can call empathy, and I think that's what we have to work to reconnect in healthcare. So thank you for your comments. Other comments or your I will statements? You're not getting away without an I will statement. We'll hold your diplomas back.
That was wonderful. This room, actually, it dawned on me that 25 years ago, I was sitting here as a first-year medical student.
Wow.
How medicine has changed. At that time, Cleveland had 4 strong health systems and lots of independent hospitals. The part of your story that was all very interesting, but the part about the sickle cell clinic where the physicians or the workers in the clinic feel such a pressure for RVUs.
Correct.
And the sort of focus now on burnout and wellness among physicians, and how do you see that playing into this in terms of making sure that the value isn't obtained at the expense of saying you do have to see a patient every 5 minutes, and here are your RVUs, here's your daily report, and those kind of pressures that are making many physicians miserable.
Correct. Yeah, without a doubt. Complex question, but the at least my view of it is, we give incentives to motivate a behavior. Right? RVU motivates productivity, and to some extent we may need examples of that. But RVU, as we gave many examples, probably has negative impact on value. So if all you care about is productivity, and maybe in a full fee-for-service you did, I would argue you probably didn't even then because of burnout, it's what you incentivize. So we are rapidly working to evolve our comp plan. We already put in incentives in our primary care docs this year for driving some of these incentives on improving value, and you're without a doubt you lead to burnout. I'll share with you how much we're evolving this. One of the pilots that we're launching, or two pilots that we're launching, one is taking a group of patients who are dual eligible, so but basically high needs patients. So you could have the same population in pediatrics or adults, and giving that doctor, they're off the RVU model. So we'll guarantee 95 or whatever. I'm still finalizing the details, but 95% of what you made last year. You'll go from a 2,000 panel primary care panel to 600. You'll be staffed with a nurse, a social worker, an APP, and your incentive is to drive down total cost of care. And you see that patient for as long as you want, because I trust that 15-minute cycles is like the stupidest thing you could think of if you're trying to keep people healthy at home. I mean, it's just, again, there are some visits that might make sense for that. You show up with strep throat, that production model. But most of what, and I'm not a primary care clinician, but most of what you see, it's complicated. Imagine if your plumber showed up at your house and 15 minutes was up, and you say, oh, did you fix the leak or whatever it was? And he said, nope, but my 15 minutes are up, goodbye, you gotta get out of here, right? I mean, like, why, whoever thought that would be a great way to keep people healthy at home? Again, because the narrative was, it's just all on value. I mean, it's all on volume and paying per click when you're incentivized to something else. So we are rapidly working to evolve that. And I mean, just this week, CMS announced 5 new payment programs, all on primary care, assuming risk for total cost of care. Our primary care model would be crushed in that, because our practices have no infrastructure. Because if they have staff in their clinic, it comes out of their pay, essentially. They have very low MAs. They have no nursing staff. So the second pilot is we're literally putting in, through the ACO resources, a nurse, a navigator, a pharmacist, a social worker. We're working out the ratios of how many per physician FTE. But the point is, we can't keep thinking we're going to run the same way and get a different result in managing value. And we will figure it out. The part of why we all need to do this is, are you familiar with, or did you get exposed in your medical school, the difference between a complex or a complicated problem, like this idea of complexity sciences? No. So complicated problem is like baking a cake, right? The rules are clear. You know the evidence. I could, read an order set. I can make a strategy. This is how you treat heart failure. Complex problems are when it's really unclear, when things are interdependent, and small upstream impacts could have enormous and big downstream and often unpredictable. So CMS payment policy, right? They change something in their payment policy. They don't plan on all the gaming, and next thing they know, oh my God. Us learning how to treat value is a complex, not a complicated problem. You can't make a strategy for that. We know some principles, and the difference between the two is a complicated problem, you can go follow the map, you can make a strategy. A complex problem, you need to innovate, experiment, and learn fast. And so we don't know if these are the right way, but we're putting in models, we'll study them, we'll revise, and we'll make the next prototype to try to figure this out fast. And it will take a lot of people working together to figure out how to do that. Other questions or I will statements?
Do they
No, they're more complex. I don't think they're that more difficult, but clearly you have some experience, so tell me why you think they're harder.
Because like the sort of a mission of like any academic center, like hospital, would be patient care, research, like fundamental research, and then also teaching, so residents and medical students. And obviously research and teaching residents and medical students is not, there's no like value for patient care in that. So it seems like it would be harder.
Yes, so great question, and that's what some policymakers and some employers are doing. So if you look at what are called narrow networks, which is that insurer says you can only go to these hospitals, 40% of them exclude the academic health center. I happen to believe that academic health centers give enormous value. It's just the discount rate. It's a longer time horizon for that value, i.e. you're our dividend, right? And so we have to make that value more clear. And same thing with scientific discoveries, that we need to make it much more clear. And we could do that. There's a big policy agenda that we're working to do that. At the same time, there's no doubt that we can get more productivity out of our academic health systems and even do better science than we do. Let me give you an example. One thing we put in at Johns Hopkins is 1 mission a day. What do I mean by that? We used to have a cardiologist, say, or whatever clinician you want, that would be seeing patients, but they'd be really late on rounds because they're doing their research in their office and then come late. So they were kind of distracted in their research because they're getting paid. They weren't really efficient, this myth of multitasking. And then they'd round really late in the evening so patients couldn't get discharged. And we evolved it to a system to say, hey, I get it, but let's focus. When you're clinical, be all in clinical, right? Get your work done. And when you're research, be all in on research so you get much more productive. And there's ways to do that. I think the same thing, an AMC is always going to cost more than a community hospital. We get it, there's no doubt. We have to find ways to demonstrate that value to the public. We're working on it. And more importantly, make sure that what's done in an AMC really needs the value of an AMC. So for example, I don't know if anyone's going into ophthalmology or someone's going into ophthalmology, doing cataracts in this really expensive health center doesn't make any sense, right? They could be done in much less costly. You still need residents to go there, but you wouldn't have all that fixed cost. But we do higher end care in here where you do need the technical complexity, and there's clearly a value proposition for doing that. And so I think it's, again, the future generation like you are going to have to figure out the value proposition, because what is the most frightening thing for academic medicine is now even policymakers are saying every one of our missions are under threat, right? Is GME investments really worth it? And, they're trying to cut that. The NIH or ARC budget is always under threat to say, what am I really getting for it? And part of why I challenged you in the beginning is to think like an engineer, do this implementation science, because mostly what they're saying is show me what I bought for my $39 billion NIH investment, right? And the public has a right to do that. I personally believe for too long, we as academic believed the end goal of those investments is just new knowledge, right? I can't tell you how many times across the country people think the goal is publishing a paper and they don't even work to implement that knowledge in their own health system, right? I mean, and it's no different here. You see that all the time. I got my grant, I wrote my papers, my job is done. So, okay, well, yeah, that's great, but are patients benefiting from that? And because we haven't, the field that I do, what's either called health delivery science or implementation science, in many places isn't even viewed as science. I mean, it's I don't know what it's viewed as, but it's that last step to make sure that these discoveries are actually applied into practice, and we've, I think, neglected that science piece of it. And it's a science that draws on social science because a whole lot of behavioral change and behavioral economics and informatics and engineering. But because we haven't done that, Congress rightfully says, okay, I see all these great discoveries in almost every field, and yet medical error is the 3rd leading cause of death because you're not applying some of these things or most of these things that we know that works. Why are you asking for more money? So some of it's we got to look inward and create the case that we do add value, because I believe academic medical systems are the future. And there's compelling data that we're the engines for economic growth. You're the future of American medicine, and we have to support it. But we can't just say, keep giving me money because I'm great. We have to do our own homework and demonstrate that we add value to the U.S. taxpayers who ultimately are funding GME and NIH and other research. Maybe time for one last question or comment?
You've described nicely how we envision fixing this from the system side. But one thing that you're going to tell me I just need to believe, because I believe in that a lot. Stop. But at the other end, you have patient-specific factors. And, you know, you used the description of your lady, I think, is Helen, that
Mm-hmm.
receives admissions for a higher you know, to take a half dozen medicines at different doses multiple times a day is a skill set that most people don't.
Yeah, so you're spot on. And
So how does the system fix that?
yeah, so exactly right. So we'll unpack. That's a brilliant insight and question. We know that non-adherence to medicine kills 100,000 people a year. Just again, breast cancer, 30,000, prostate cancer, 31,000, non-adherence. And think about what we're asking this poor woman to do, and we haven't trained in the skills or the tools to make it easy. We could, but we haven't even viewed that as our responsibility. I did some work on medication adherence, and 4 simple questions answered 95% of non-adherence, but we don't routinely either ask or solve them. And they were, Mrs. Jones, why do you not take your medicines? You added complexity. There's 6 of them, but this could be for any individual one. I don't believe I need it, which is common for blood pressure or a variety of things. I don't like how it makes me feel. Again, common for a lot of things. I can't afford it. Different solution. And I can't get a ride to pick it up. Different solution, right? And then there's an other. But systematically asking those 5 things, and they all have a different solution set, we would address it. We could make it a lot easier if we, again, thought like an engineer and said, you know, whether it's pill packs. But one of the things I want to even pack deep with you, because there's no doubt that personal responsibility plays a big role in this. But one piece of science, and it gets to your empathy, that we need to understand is this research on scarcity. Again, I don't know if you were exposed to this. It's key, especially if you're going to be caring for anyone, but especially poorer people. The scarcity literature says that though we often think of behaviors as willpower, you know, I eat healthy or I not because of my willpower, or I exercise because of willpower, what it's convincingly showed is that we all only have so much decision-making capacity in our day, and that once it's spent, you're spent and you can't do it. And it's not something that you will, it's biologic. We could only do it. For most of us, we can get through our day because we're not making all that many decision-making, and not right or wrong, but it might be at the end of the day you have a glass of wine or some comfort food because you got it. And those of you who travel for academics might know it's a little more stressful, so you might like comfort food when you travel. God knows I certainly do, because it's stressful. If you're poor and you have to count your pennies to see how I could go to the grocery store and afford to feed my family, and literally like you're trying to do the math of saying I can't afford this, or I could eat on Monday, I can't do it on Tuesday, you're spent just getting through your day. And so though we could often say you need to be, you know, have greater willpower, why do these people come back? Because biologically they just used up all their decisional making capacity, and what they need is support. You know, and not saying that your question was judgmental, but we need, to your point about empathy, and try to understand that unless we connect these people to social services, like this is going to keep happening, right? Because that Helen came in all the time. She needed a ride. I mean, and she was spent just, you know, caring for that preemie or ex-preemie who was really demanding it in her age, and you know, trying to hold down a house together. So great question, and you know, it's. That question, perhaps it's the last idea I would leave with the plea for the students, is, you know, you have been skilled and embraced biomedical sciences, and you leave here with, I would assume, I hope, a good grounding in biomedical sciences. I would encourage you to also be students of social sciences and leadership and how to lead change. Because all this stuff that you're trying to navigate into healthcare, it's mostly in the social sciences. And I strongly believe medical schools need to train much more in management and leadership and leading teams, which you have, but also in these social science ideas, because some of these things are so key to managing populations, you shouldn't be hearing them from a hack guy at your AOA lecture at the end of your years. So I thank you, and congratulations on your induction, and best of luck in your future.